Hello everyone, my name is Ariel Mencia, and I'll be presenting my FRP presentation examining the impacts of structural racism in medicine. When we think of healthcare, we often think of doctors, hospitals, and life-saving treatment. But what if the system that's supposed to heal is actually built on centuries of racial injustice? What if the way we train medical professionals and the way we deliver care is shaped by the legacy of racial bias? Today, I'll explore how structural racism in medicine continues to impact healthcare both in education and patient care. Before we dive in, let me give you a brief overview of what we'll cover. Structural racism isn't just about individual problems, but it's embedded in systems and structures that shape our daily lives. While medical education and healthcare systems have undergone some reforms, historical and contemporary discrimination continues to affect students of color, as well as the quality of care that minority patients receive. My research examines three key points: the unique challenges faced by medical students of color from admission to graduation, the factors that help sustain their well-being and success in the medical field, and the way in which the medical curriculum can better prepare future doctors to address health inequalities head-on. Research question. My research question was, how do structural factors in healthcare systems perpetuate racial disparities in patient care, and what reforms are needed to address them? Despite efforts like affirmative action, minorities are still underrepresented in the medical profession, and they continue to examine and experience poor health outcomes compared to their white counterpart. This creates a vicious cycle minority groups face, which lead to poor health, which in turn affect their access to education and employment in healthcare fields. Understanding these barriers isn't just an academic exercise. It's essential for addressing the broader social inequality that we all live with. Research topic. To narrow my focus, my research was specifically looked at the challenges faced by medical students of color, particularly first-generation students. I investigated three key areas. One was the challenges these students face during their education. The second one was the factors that support their well-being and help them succeed despite systematic obstacles. And three, the ways in which medical curricula are preparing these students to combat health inequalities they will encounter in practice. My thesis was African Americans have faced vast amounts of discrimination in the United States since the early 19th century. Despite this, they have managed not to only survive, but live and thrive in the United States. Through education, protesting, and seeking careers, African Americans have attempted to break through the systematic racism and attempt to create a social mobility. At the heart of my thesis is a recognition of resilience of African Americans and the other marginalized communities. Historically, these groups have been excluded from education and healthcare systems, but despite this, they have consistently sought education and career opportunities to combat the very forces that seek to oppose them. From the moment slavery ended and the civil rights movement began, African Americans and other people of color in this country have fought for social mobility and the ability to break through barriers in all sections of society, including medicine. But while progress has been made, these barriers still exist. What is structural racism, and how does it affect minorities? To understand the full scope of the issue, let's first define what structural racism is. Structural racism is a set of policies, practices, and cultural norms that systematically disadvantage certain racial groups, particularly Black, Indigenous, and other people of color. This isn't about an individual act of racism. This is about deeply ingrained systems that express inequality. Structural racism show up in countless ways: in unequal access to healthcare, underrepresentation of minorities in medical education, and in how patients of color are treated in the healthcare system. To understand why this is such an issue, we need to look back into history. One of the most important examples of structural racism in medicine was the Tukhetsky study, which ran from 1932 to 1972. In this study, hundreds of black men were denied treatment for syphilis even after getting their standard treatment. The men that were not informed of their dialysis, nor were given their option of proper care. This study is just one example of how racist practices have been embedded in medical research and treatment for generations. Beyond that, we see a broader pattern of segregation in hospitals and lack of representation of people of color in the medical workforce. This legacy of racism continues to haunt us today, contributing to both healthcare disparities and the unrepresentation of minorities in the medical field. The historical legacy translates into disparities. Considering how healthcare funding is distributed, communities and people of color are often in areas of fewer resources and less access to healthcare. Moreover, there's still little accountability for discrimination practices in healthcare. Patients of color are often met with lower quality care and biases from providers. This perpetuates mistrust in the healthcare system, and that mistrust further causes health disparities. How are minorities facing discrimination? It's not just healthcare that is affected, it's education too. Minority medical students often face additional barriers in their training. Many of them lack the same access to mentors and networks that white students have. This absence of support is compounded by the bias that exists in medical curricula, which often neglects or misrepresents the health issues facing marginalized communities. In addition, standardized testing such as the MCAT disadvantage students from underfunded schools, many of whom are from minority backgrounds. This is an example how racism is embedded into the system that we use to determine to become a doctor. Upward mobility through government. Even after entering the medical field, many minority students and professionals face discrimination. For example, minority patients are most likely to experience bias in treatment, with doctors making assumptions about their pain tolerance or ability to understand medical instructions. Even with laws like the Civil Rights Act in 1964 and the rise of diversity, people of color still encounter major barriers, especially when their socioeconomic status intersects with their race. This helps highlight the need for policies that recognize how race, class, and health outcomes are interconnected. How has structural racism changed over time? Although there's not much change, there's still some hope. One of the most significant reforms in recent years has been the Affordable Care Act, which aimed to reduce health disparities through increased access to care. The ACA emphasizes improving healthcare access to underserved communities, and it encourages data collectors and collections on race and ethnicities to inform policies and practices. In addition, former President Biden executive order aimed at addressing systematic discrimination signals a step forward in acknowledging and combating these issues in federal agencies, including healthcare. This slide shows how the racial demographics of medical school applicants have changed over time. From 1977 to 2007, we can see that while the number of minority applications has increased, the acceptance rate for minority groups remained lower than those for white applicants. This gap reflects the structural barriers that continue to prevent underrepresented minorities from entering the medical field. Conclusion. To conclude, structural racism is not just a relic of the past. It's alive and well in many medical institutions and healthcare systems. While progress has been made, we continue to push for change, but we still need more diversity in leadership, more accountability in healthcare, and a curricula that addresses the historical and ongoing injustices in our healthcare system. This is not just a problem for medical professionals to solve, but a responsibility and a demand for change that we all wish for. Thank you for your attention, and I've included a list of my resources and references here. I encourage you to explore them further because the more we learn, the better equipped we are to dismantle these types of system of inequality. Thank you.